Good afternoon. Dr. Hal Danzer from Southern California Reproductive Center, and this is Breast Cancer and Your Fertility webinar this afternoon. Thanks for joining us. It's timely. This is Breast Cancer Awareness Month, and we're here to talk about breast cancer and fertility preservation, specifically for those patients that have breast cancer. My co-host today is Dr. Carolyn Alexander. She's one of our 6 SCRC doctors. I'm one of the co-founders. We've been here for 20 years. We talk about SCRC, many couples or individuals that come to do IVF or freeze eggs. They want to know if we're going to be here in the next 5 to 10 years. And we certainly have new associates, and we plan on being here for another 20 years at least. Luckily, with our 6 physicians, and actually soon to be 8, we've established the largest IVF center here in the Los Angeles area. Our laboratory that freezes the eggs and makes embryos is internationally known. We've been in the top of the success category for since the very beginning. We certainly founded SCRC on the premise that we could keep our eye on the horizon for all the latest technology. And I think we've been able to do that. And again, when you have a large center, we do over 1,500 IVF cases a year. We're able to have an excellent group of embryologists and physicians to keep us on pace to be at the forefront of all fertility treatment here in the US. Dr. Alexander is noted for her kindness and gentleness, and certainly I've respected her for her great expertise in this area and her judgment. So I'm going to start off, and then Carolyn will pick up in just a little bit. So again, about just mentioned about Southern California Reproductive Center. It's important that people call and say, "Well, I saw you online, or I had a friend, but what makes SCRC different?" And again, we talk about a track record, what makes us the best in class. And when we look at our laboratory that does over 1,500 IVF cases a year, and that's important, we have about a dozen embryologists. And we have the luxury, because we have a large program, that we double check everything that's done. When one comes in for an egg freeze cycle, we have a dedicated embryologist for that particular person. They don't switch off. That's how mistakes happen. So we're able to have not only a dedicated embryologist that receives your eggs once they're retrieved, and that same embryologist will then go through the entire freezing process. There's no handoffs. And also there's a second embryologist that then identifies every step of the way, that there's a kind of a second check. We don't want any mistakes made in terms of identifying eggs or embryos. And that's what is recommended, and what keeps your eggs and embryos the safest as they can be. You see here on the diagram about the kinds of things we do in the laboratory. So the laboratory is sort of the backbone of the fertility clinic. The doctors obviously prepare the patient and monitor the stimulation process to mature eggs, then do the egg retrieval. And again, you have a dedicated physician that stays with you. We're not a doctor of the day. We have continuity all the way through with your same doctor. And that's better for us and better for you. We do not trade off even on weekends, fortunately or unfortunately. So again, you can see the procedures that we do here. Assisted reproductive technology. We do genetic testing of embryos. We do embryo selection. There's a little diagram about how you insert sperm into the egg when you make embryos. The hatching process. All of this technology has evolved over the past 20 years. And as we see pregnancy rates close to 80% with a genetically tested embryo. And that success rate is dramatically improved over the past 10 years. Today, when we freeze eggs, the thaw rate, which 50, 60, 70% was good with the old technology. Today, the thaw rate is 80 or 90%. So that if you have 15 to 20 eggs, we looked at 15 to 18 of those eggs can be thawed successfully. And then fertilization rates, are about 75 to 80%. And that's important because you want to get an embryo formation for as many eggs as you can. Sex selection is an issue for some couples and sometimes some genetic issues also. The egg freezing technology, as I say, has really evolved dramatically in the past 10 years. The freeze and thaw rates are dramatically better. People ask us, where do you store the embryos? Where do my eggs go? Well, they stay here at the same place, SCRC, there in Beverly Hills. And we have a monitoring technology that looks at the canisters that contain the frozen eggs and embryos. It's monitored continuously, remotely with video and with other monitoring electronically. But there's no electricity involved. If the power goes out, the liquid nitrogen is good for days afterwards. So they're very safe. There's always some concern about earthquakes in Southern California. We don't transfer any eggs or embryos to Colorado. I think this building that we're in is safe from a very strong earthquake. Some of the other new technology in our laboratory, again, the genetic testing of embryos has dramatically improved the success rate. We used to transfer embryos that were genetically not tested. Pregnancy rates were 40, 50%. Today, with transferring a single genetically normal embryo, the pregnancy rates are 75 to 80%. So genetics is a big piece of selecting the very best embryo to transfer. We have a new technology called the embryoscope, and that's the next newest level of technology to monitor how symmetrically an embryo develops. So we fertilize it, it goes 2, 4, 8 cells, and then goes after that up to 100 cells. But the first 2 days of cell division, if it's symmetrical, 2, 4, 8, that qualifies it as the very highest quality embryo with the greatest potential for pregnancy. We see embryos that go from 1 cell to 3 cells, 5 cells back to 2 cells. When you have this asymmetrical development of embryos, the pregnancy rate drops to less than half than it would be for an embryo that is going 2, 4, 8 cells. So again, it's a new technology that allows us to rank embryos, the ones that have the greatest potential, so the time to getting pregnant is the shortest possible. So as we go on to the next slide, everyone asks, how do you prepare yourself for an egg freeze cycle or an IVF cycle? They're both essentially identical. How do you get your body in the very best place? More difficult in the pandemic than it's been before, but good nutrition. I wish I could tell you the magic food, but we talk about Mediterranean diet, plant-based nutrients. I think there's good evidence that is just better for your health in many ways. Acupuncture, we have an in-house acupuncturist now who helps is assists in getting the body in harmony, preparing for an IVF cycle and during. It's a stressful time. There's a lot of visits and hormone changes and anything that you could do to get the body in harmony and keep it in harmony during the procedure is a benefit. I'm a great advocate of meditation. I don't know how many of you are mindful, but again, to revisit your mindfulness is really important in going through any sort of a medical procedure, but certainly something like freezing eggs where there's so much fluctuations in hormones. I think mindfulness is a great advantage in all sorts of medical treatments, but certainly for the stimulation process. We can go to our next slide. So what are the options for cancer patients? And we were talking about the frozen eggs and embryos, well, sperm also in these tanks. And again, the tanks are rated to, I think, an earthquake of 7.5 or 8. They're very stable. They don't have any electricity that is necessary to maintain the temperature. The temperature is monitored very carefully electronically and daily, but they are very safe. So sperm freezing technology, men that are going to have treatments for testicular cancer, we see regularly, where they have to remove the testicle because of a cancer. Freezing of sperm, again, doesn't take much time, just several days to a week before their treatment. We can get several sperm specimens which can be frozen for use in the future. Egg freezing, unfortunately, is a little more involved because we have to mature an egg, which takes 10 or 12 days. That's when a woman generally ovulates. But the human ovary wants to release one egg with a stimulation protocol, with injections of natural follicle stimulator. We want to generate 15 to 20 eggs in a given cycle. That's sort of the average. But it takes about 12 days of injectable medication to mature the eggs, and then retrieval is performed to retrieve the eggs from the ovary, and then they're frozen in a matter of hours afterwards. So this is what they call the quick freeze, rapid freeze, and that's the newest technology that allows for this probably almost 80% thaw rate. Eggs can be thawed at a time in the future if a woman has a partner and they say, well, it's time to be pregnant. Or if we have to wait for chemotherapy for some women with breast cancer, they may not give the okay for pregnancy for 4 or 5 years. However, during that time, you can thaw eggs, fertilize them, and grow embryos, genetically test the embryo, and then it could be transferred to a gestational carrier, or what we call a surrogate. So egg freezing can be done prior to any chemotherapy or a surgical procedure for breast cancer, but you can create embryos at any time after that. Embryo freezing, again, we freeze today mostly genetically tested embryos. It takes about 5 days to grow the embryos to a 100-cell blastocyst stage. At that point, the embryologist can take several cells from each embryo, then freeze the embryo, and send the cells out for genetic testing. The results come back in a week or so, but again, the embryos can be frozen for 5-10 years. So this technology is very well established today. It is very successful and opens the door for a woman who has have to undergo treatment for her breast cancer to leave all the options open for a future family. Next slide. So how many women get breast cancer? And the 11% of breast cancer cases occur in women over age 45, but we know that approximately 12% of all women will have breast cancer sometime in their life. Obviously, many breast cancers are past for the time of fertility, but again, 11% are in younger women who want to preserve their fertility for the future. So there's 16,000 to perhaps 200,000 women diagnosed are of childbearing age. And that's why this technology has such an impact in allowing women to preserve their fertility in spite of a cancer. And luckily today, breast cancer is very treatable. It's detected much earlier than it ever has in the past. Remember, as a personal note, my mom was diagnosed with breast cancer in late 60s in a very early stage from a mammogram and had surgical treatment and lived to the ripe age of 98. So that was a real success story. And certainly in my wife's family recently, there was a positive for the BRCA gene, which again, has caused other members of the family to be tested. So there is genetic predispositions to breast cancer, and that technology is evolving. I think in the near future, we'll see more and more genetic testing that allows us to identify specific markers for those women who are at greater risk for breast cancer. So if you're 1 in 12, that's kind of a scary number. But if you genetically are not in that category for predisposing reasons, less stress in terms of the future. But mammography and these other modalities today have been very successful in diagnosing women at a much earlier stage when the cancer is much more treatable. Next slide. So at Southern California Reproductive Center, we certainly work very closely with the oncologist, and that's important. And we want to be able to move quickly. Again, we have, say, 6 physicians here in a full-time laboratory, work essentially 7 days a week and 12 months a year, so that we're able to accommodate any woman that has the need for freezing of eggs or embryos for the future. And again, if women have had chemotherapy, there may be some residual ovarian activity depending on the type of chemotherapy. So the woman may come in and have an evaluation to see what their egg reserve is even after the chemo, and may be able to undergo what they call a stimulation process to retrieve eggs from the ovary even after chemotherapy. And then we ask about, well, does IVF affect cancer? And I think that's very clearly not the case. Stimulation of the ovary with injectable follicle stimulator, which is the natural product, generates a little higher levels of estrogen for that 8 or 10 days. But that can be managed by newer agents that kind of block the estrogen levels. So it's very safe for women prior to having the surgical procedures for breast cancer to have the IVF to retrieve the eggs. So that treatment protocols have lessened the stress that everyone thought was there because of higher estrogen levels and predisposing to cause the breast cancer to grow in that month ahead of time. And that does not seem to be the case. Next slide. We talk about sperm freezing, and again, there's just a chart to look at. So sperm counts are 20 million. Sperm factors may account for a lot of infertility issues. However, cancer for men, no matter where it is in the body, usually does not affect the sperm production. And so we see many young men for testicular cancer, but other types of cancer, skin and so on, bone. They're certainly able to freeze 2 or 3 or 4 or 10 specimens prior to any of their treatments. And this allows them to have a fertility potential in the future. We freeze in what they call vials. We use like 1 vial per IVF cycle. And usually with 1 ejaculate, you might be able to get 2 or 3 vials. So there's plenty of sperm available for in vitro fertilization. Then they're able to freeze 10 or 12 vials and may be used for intrauterine insemination in the future with a partner. So sperm freezing is something that's probably not talked about as much as egg freezing. I think it's coming more into the community to realize that even young men should protect their fertility in the future if they're undergoing any sort of fertility or any fertility compromising treatment. Sometimes that's not just cancer, it can be treatment for other sort of autoimmune illnesses. Next slide. So here we are with Dr. Alexander. She's as pretty as those orchids in front of her. And
Thank you, Dr.
We'll hand everything over to you.
I always think of how you've taken care of patients and even helped their kids too with hormone imbalances and stuff too. So It's such an honor to work with you and our team here at SCRC. I feel like we have a really collaborative team. We all work hard together, and it's like everybody's on the in the same goal to get healthy eggs and to keep them safe for you guys for the future. Next slide. My part of the job is to talk a little bit about the process, like what happens when you call and come in for either a video call or an in-person call. So next slide. So we'll take a detailed medical history. It's really important to be on vitamins, like Dr. Danzer mentioned, is kind of centering yourself, taking the time to do, if you like acupuncture, yoga, and exercise. Walking is encouraged during the IVF process for egg freezing or embryo freezing, because we don't want vigorous exercise when the ovaries are getting enlarged. We also want you to limit not too much caffeine, a little bit's okay, and not too much alcohol, as well as we verify that your thyroid level's good, your prolactin, vitamin D, to kind of keep things in check that can influence egg quality. We do a physical exam. We want to make sure you're up to date with your pap smear. If you've had a recent diagnosis of breast cancer or find out that you carry the BRCA gene, we like to chat with your doctor to make sure we get the clearance from them to jump in and do the few weeks of medications. On average, it's 10 to 12 nights of injections. And the injections are called FSH, or follicle stimulating hormone. They've been around since 1962. These medications really help get the best eggs to pop up, because each month you have a blessing of a group of follicles, and nature ovulates one egg. But what's kind of magical is if you start medications, we can actually blossom 5 to 20 eggs instead of just the one egg of the month. It's important to do diagnostic testing with our patients with any type of cancer. I just got called to see at 7:30 tomorrow morning a patient with a yolk cell tumor, like a rare type of a cancer. She's very young. So we'll see her right away, and they don't give us much time before chemo to think to freeze some eggs for her. The diagnostic testing is what we'll talk about next. Next slide. It's very important to look at your AMH. It's a hormone blood test. It's not a perfect test, but it's a hormone level that's produced by the cells around your eggs, called the granulosa cells. AMH should be at any age, any time. We're hoping for it to be above 1. When we're under 35 years old, it really should be above 1.5, but we're really just trying to get a sense on your egg supply. If AMH goes below 1, it doesn't mean that the egg supply is bad. It just means that time's not necessarily on our side, and it might be a little more time sensitive to think about getting some eggs frozen or embryos, which are fertilized eggs, and discuss the options. There are a couple ways to improve AMH with some vitamins called DHEA, as well as acupuncture, diet modifications. If your BMI or body mass index is above 30, trying your best to get it down below that if possible. We also do an ultrasound at any day, anytime. And that is important because that's how we count how many potential eggs we're able to recruit with our protocol with the medications. And here at SCRC, I'm really proud, but we give a lot of individualized care. We don't just give the same kind of medications to everyone. We really think hard. All of us put a lot of heart into it to get the best quality eggs and quantity to pop up, and make sure you're feeling well during that 10 to 12 days of injections. Next slide. So in terms of initial recruitment, like we talked about, the AMH, or anti-Müllerian hormone, is one of the early predictors, as well as a hormone blood test called FSH and estradiol, which are done on your 3rd day of your period. Those blood tests, we sometimes don't have time with our cancer patients to get to the 3rd day of the period, but we can get a sense on the levels by checking them. We also, with the follicles, get a sense. The picture on the right shows Each black circle has one potential egg inside, and we count with our ultrasound team who work really hard here to count how many follicles we have and to plan your protocol. Next step. In terms of optimizing, taking your vitamins, walking, eating a lot of fruits and vegetables, the stimulation or shots takes around 10 to 14 days. And then there's a 20-minute procedure called the egg retrieval. It's done through the vagina under light sedation. So you do have to get through your vein propofol just for a short period of time so that we can carefully get the eggs out. That night, you really can't do very much. So a lot of people don't go to work that day, and you need a heating pad and Tylenol ready because you'll be a little sore for about 7 days. The most common complaint is constipation. So it's important to take milk of magnesia or Miralax to help avoid that. And then within an hour or within 3 hours, we freeze the eggs or we fertilize the eggs. If the AMH is really low, there is a big discussion with you about talking about fertilizing some of the eggs. If you don't have a partner, it is more emotional to discuss that. But at the end of the day, a fertilized egg is stronger than a plain egg. So it's important to think about all your options when you're trying to really plan out fertility preservation, especially if you might be receiving chemotherapy that's pretty strong that might affect your future fertility. Next slide. This is a beautiful picture of the follicles. Each black circle has a microscopic egg inside, and over the 10 to 12 days, each follicle grows. There's a certain size. Each team has their own sort of desired size, but 18 to 22 millimeters is the target. Once the follicles get to that size, the egg hopefully is mature so that it can get frozen. We can only freeze an egg that's what's called mature, where the polar body is extruded. If they're immature, sometimes we do freeze them for our cancer patients, but it's harder for them to survive the thaw. So it's helpful to get the follicles to grow to a certain size so that we can get a mature group of eggs. Next slide. And this is a depiction of the thin needle. It's smaller than a blood draw needle that goes in through the skin of the vagina directly into the follicle, and the egg sits in the cumulus region in this gray area. We carefully drain the follicle, and the team tells us egg, and then we go to the next follicle. We try not to poke through the vagina too many times. So one time can get us an approach into the ovary carefully, and we all do retrievals every day. And so our facility is very safe. We have an experienced anesthesiologist. He's been with us for 20 years. And we work closely all together to safely get those eggs out. Next slide. This is a beautiful picture. This is the egg when they look at it here, and then they clean off the egg and zoom in. This is the polar body. Sometimes if patients have endometriosis, the egg can have a darker or granular appearance. And sometimes in some situations when we're older, I had my kids older too, so I understand that the zona pellucida, which is the outer rim, can seem a little different in some situations. And that's why, as Dr. Danzer alluded to, when we're really talking about statistics, we know around 35 years old, we figured out that 15 to 17 eggs should get us a chance for a pregnancy as long as the future sperm is healthy. When we're towards 40, we need 25 to 35 eggs to get a chance for a pregnancy, because not every egg survives the thaw, and not every egg has proper genetic complement of one chromosome of each of the 23 chromosomes. And so it becomes a little harder for us to get a genetically healthy embryo as we get older in age, including the man's age too, especially when men are over 50. Next slide. So this is a bar graph of some statistics. So women under 35, when they had about 15 eggs, there was almost a 90% chance of a live birth or pregnancy. And then when we're over 35, we need a bit more eggs to get a chance for a pregnancy. We've all had patients though have a few eggs, thaw them, and get a healthy pregnancy and didn't reach the 20 egg mark or 15 egg mark. So that's happened many times over these years, but it's still important to educate patients so that they understand that we're all trying our best to get as many eggs as we possibly can, but sometimes that group of eggs only gives us 5 eggs, and sometimes we don't have another opportunity to get more eggs before chemo. And so we do the best we can. I call each egg a golden egg and a chance for a healthy pregnancy. So we do our best, and our team works hard in the embryology lab to thaw those eggs and work hard to fertilize them and grow them. Next slide. Embryo freezing. Next slide. So there's 2 ways to fertilize an egg. We can either dip the egg with 20,000 sperm, or this is a depiction of ICSI where the egg is fertilized with 1 sperm. They spend a lot of time picking the best quality sperm. And then the next morning, we want to see the embryo as 2 cells. Next slide. This is a picture of the embryoscope, which is right here is 2 cells. And then it's going to grow to 4 cells, then to 8 cells, and then it'll become 1632, and then to a morula, which is a ball of cells, till it becomes a blastocyst, which has the inner cell mass and the outer trophectoderm. The embryoscope provides us 1,000 data points to compare embryos. And so sometimes we'll have 2 really good looking embryos, but the embryoscope noticed 1 difference in one of them, and we'll pick the other one as our first embryo transfer versus the other one. So we all spend a lot of time trying to pick the best embryo to transfer later when you're ready to carry the pregnancy, or if you have health issues or the breast cancer and your oncologist calls us and says it may be better to use a surrogate, then we work hard to get you a surrogate, a healthy surrogate, and we place the embryo in them. Next slide. So we're very proud here of our IVF success. Even what's kind of fascinating is since COVID, our stats have even gone up, but I think it's partly because a lot of patients aren't traveling as much. They're not as stressed. There's a lot of working from home. People are more focused on exercise and eating maybe healthy because they have a bit more time. They're not in traffic in LA in their car. So we're noticing our pregnancy rates gone up, but we've been about 80% in our women less than 35 once they have a normal embryo. So that's the first hurdle, is to get a genetically normal embryo. And then 35 to 37, we've been at 76%, 38 to 40, 70%, and 41 to 42, around 65 to 80%. Next slide. Why do we use a gestational carrier or surrogate? And there's many reasons. Some patients have uterine cancer and they have to have a hysterectomy. Some of our patients have really bad lupus and they are not allowed to carry due to potential kidney disease that they could have. Breast cancer, if it's been a severe case and it took a lot to annihilate that cancer, then the oncologist will encourage us to use a surrogate. Single men and same-sex couples use surrogates as well. We work really hard to get our patients the healthiest surrogates. We talk about their BMI, we make sure they're on vitamins, we review their OB history. We have 5 people on our team working hard to help us get the best surrogates. I feel like it's been really a blessing and a wonderful team to work with to get healthy surrogates here. The state of California is very lenient with surrogacy, so it's always the biological parents or the parents of that embryo that are the parents of that child. And so it's been a blessing to help people through gestational surrogacy here. Next slide. Our team, like I said, we all work well together and we take good care of patients, and we're happy to answer questions, Dr. Danzer and I. Next slide. Let's see. If anybody has any questions, let me see where we go. And make sure to save, mention breast cancer awareness webinar. and you'll get half off your consultation with us. So that's nice. And then let me see if there's any questions. I know a common question is, like we mentioned, how long can the eggs stay frozen? We've had healthy babies from eggs frozen 12 years ago. Some facilities don't have that long-term safety data. We've had embryos frozen, I think, over 20 years in healthy babies, and we've had sperm since the 80s. So we've had a long time of monitoring things here. And a lot of us keep close contact with all our patients, so we hear about their pregnancy and delivery and the surrogates and everything too.
Carolyn, one of the other questions everybody asks is, how many eggs do I need and how many eggs can I get from my ovary? And it's individual, but maybe you could just talk about that again, because that's the most common question we get.
Thank you for joining us today. Wish you a safe journey ahead.
We have questions coming up, but they're not reading.
Are they?
Oh. Yeah, Carolyn, it was just the most common question we have is, how many eggs do I need and can I get 15 or 20? Maybe you can just talk about that a little bit more, because that's
sure, yeah.
Sure.
So when you come in for the ultrasound, we get a sense on how many potential eggs may develop. At the time of the egg retrieval, we get, we're hoping to get 5 to 20 potential eggs. I think that's what's interesting is that at the time they'll clean off the egg and they'll tell us how many got frozen. So we usually alert you the following day. Our patients with polycystic ovary syndrome, they do tend to get a lot of eggs, but the quality sometimes isn't as good. So we try to do a gentler protocol or gentler medication so that we don't overwhelm the ovaries. So it is sort of a balancing act of quality and quantity. I think, like we mentioned, is that around 15 eggs, around 35 years old or below, should give us a good chance for the future. When we're over 35, it does seem that we need more than that. It's hard to know exactly. Dr. Barrett, our lab director, who's a PhD, he has told us at 37 years old, it took 17 eggs in the last 5 years when we've thawed eggs to get a chance for a pregnancy. And we do sometimes with some few eggs get good embryos, like more than one good embryo, and we can save them for your second child too. And that happens often as well.
And once you get once
yeah.
a patient gets the number of eggs that they have, there's an egg calculator I know that you use too, based on your age and how many eggs you have. What does that predict in terms of the probability of a successful pregnancy? And most women in their mid-30s with 15 to 20 eggs, there's 75, 80% probability they'll have at least one full-term delivery and maybe 50% chance for two. But again, that's individualized. But again, the calculation is based on the number of eggs and the age at which the eggs were frozen.
Yeah, the first question is from the COVID vaccine, which we can send you all the link. We wrote a paper in December, right when the vaccine was happening. I worked with 8 people, including an immunologist, on trying to determine, is the vaccine going to be harmful? Because it was all so new and happening so fast. We were really stressed out that we would be hurting the patients by encouraging people to have the vaccine. And what's been reassuring is that even though the mRNA has some mimicry of the mRNA of some placenta proteins, the protein, which is what your antibody is going to attack, is not the same as our placenta protein. So we have not seen a compromise in the women who've had their vaccine and then got their eggs frozen or tried to get pregnant. Our anesthesiologist doesn't want someone who's had a fever in the last 4 or 5 days. So we're encouraging women who need or thinking about getting the vaccine to try to get it at least a week before the egg retrieval, because and if not longer. And then for embryo transfers, for a while, we were encouraging you to wait 30 days from your second shot, because with an embryo transfer, we can really time when we're going to put the embryo in, and it's more controlled. But in general, it seems that getting the vaccine may be safer than getting real COVID. So, but it's a personal decision. So each person has to feel comfortable. We haven't personally seen any data or concern. We do get anecdotal data that the menstrual cycle, even myself, seemed a little different, but it always tended to ebb back to normal within a month or two from the vaccine. I can ask the next question to Dr. Danzer. It says, if I've a known BRCA variant, can you use PGTM? Do you want to answer that one, Dr. Danzer?
Yes, with when you grow embryos and take cells from the embryo before you freeze them, they could be sent to a genetics lab that can identify what they call single genes. And there's 283 single genes that we can identify today. So they can identify the embryos that have the BRCA gene. Obviously, then you'd want to be able to transfer the ones without the BRCA gene in the future.
Yeah.
Absolutely.
It's autosomal dominant. So the trick is that every other egg gets potentially the BRCA. So we tend to need more eggs to get a normal embryo, because you're also going to be first checking for chromosomes such as Down syndrome and trisomy 18, all 23 chromosomes. Then we'll check for the BRCA, and then we go over the genetics report with you after that.
And the standard genetic screening test that we recommend for any couple or individual who's anticipating pregnancy is to do this single gene test. Again, it covers up to almost 300 single gene disorders. It's not expensive. It's a blood test, and that can identify whether you're a carrier for BRCA1 or 2, but a variety of other cystic fibrosis, Tay-Sachs, that are single gene disorders in the population. And again, the easy test to do, and anyone anticipating fertility in the future should talk to their doctor, even their gynecologist, about getting the blood test for single gene disorders.
The next question, how long do we wait from the COVID vaccine booster for an egg retrieval? We haven't been holding off on things. Just again, the 5-day rule, if you're 5 days from your retrieval, you rather wait till sort of when you're done with your retrieval, then you can get the COVID booster, because that 24 to 48 hours after, some people get a fever, and our anesthesiologist doesn't want anybody who's had a fever within the 4 days before the retrieval. So we're trying to dodge that issue before the retrieval. So potentially after, but the best is 30 days, because it seems like for 2 days, people feel inflamed and not as back to their normal self. So probably, if possible, a month. But if you're already in the shots, you might as well wait till after.
I think it's very individual in terms of how people feel after their booster shots. After my third shot, I didn't feel a single thing, where I felt a lot after the second one. So I think it's individual in terms of how one's immune system responds to the vaccine. But I think the vaccine is safe. All the studies, the guidelines are very clear that if you're thinking about getting pregnant, you should complete your vaccination beforehand. Complications with COVID during pregnancy can be very severe. So you're much safer from all the studies that getting vaccinated before pregnancy. Now, if you're going to freeze eggs or embryos, that's a lesser issue. But as Carolyn said, you'd like to have a little buffer between your booster and when you start any sort of medical procedure. But luckily, I don't think there's any studies that we've seen that the vaccine compromises one's fertility in any way, whether it's sperm counts or egg counts. That's the good news.
Well, wishing you guys all the best, and thank you for this opportunity to talk about an important topic. I was thinking when Dr. Danzer said, the chances of breast cancer, I hope in the future that goes down, realizing that there's endocrine disruptors and microplastics and all these things. But I think an awareness has risen, and hopefully I'm always optimistic that things will improve in the future too.
I mean, genetic profiles for many illnesses, whether it's immunologic disorders, heart disease, I think we're going to be able to see those individuals that are more at risk, so they have more testing beforehand to catch cancers at the very earliest stage when they're curable. And that's the hope for the future, yeah.
Yeah. Let me see if there's any other questions.
So I wish everybody a good weekend. Obviously, if you have any questions on fertility, we are available. We'd be happy to see you in consultation at any time. Thanks again. Have a very great weekend.
Bye. Have a good one.